One of the most common hormone disorders affecting women have had the same name for nearly a century. But in May 2026, after more than 14 years of international debate, experts officially announced a new name.
That's right. Polycystic Ovary Syndrome, or PCOS, is now being called Polyendocrine Metabolic Ovarian Syndrome, or PMOS.
Yes. Today, we are talking about why the name changed, what it means, why many experts believe the old name may have been holding women back from understanding what the condition really is.
Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine.
Welcome back. This is episode 77. We're in season 2. And we're going to talk about PMOS. Like, I feel like, first of all, they just made the name, like, say that 5 times fast, Polyendocrine Metabolic Ovarian Syndrome. They did make the name more complicated.
Yes. Yeah. Which I do really love that the name was changed. It is a little bit of a mouthful.
Yes.
But I think it also helps you understand it more as well, because it is like a full body affecting your whole like metabolic process, your endocrine system, all the things, and like may or may not affect your ovaries as well. So I'm glad that like all that was encompassed in the name.
I know. And I mean, I know if y'all have been listening for any amount of time, you know that I have PCOS. And so I don't care to share that. It's fine. I feel like now that I'm like have my babies and I'm past that part of it, I feel like that's what was really like so scary to me. And I feel like that's probably true for most people. It's like so wrapped up in your ovaries and your fertility. And like once I got past that, it's like, okay, we can deal with the rest. But most people don't even know there is a rest, right? Like that there is a future after having babies, that your PCOS continues to cause problems. And so, like, to this day, I am insulin resistant and probably inflamed because it's hard to stay conscientious about the things that I need to do to control that. But so this was probably PCOS was probably like my biggest passion for like wanting to get into hormones in the first place. And I remember thinking the whole idea of like women taking testosterone was insane because I had PCOS and my testosterone high. So like, what? People want this? I want mine lower. But it is weird now that I'm 45 and coming into perimenopause and all that is changing, and my testosterone isn't high anymore, probably just with the downregulation of all that hormone production out of my ovaries. But yeah, PCOS has for a long time been my why behind this hormone stuff. So it is pretty cool that people are finally starting to recognize it across multiple genres. Like the official international consensus name change was announced May the 12th. So, you know, just a little over a month ago. And it was published in the Lancet. So that Lancet is a big medical journal, not just something that OBGYNs or hormone providers or whatever read. I mean, cardiologists, family practice doctors, everybody reads the Lancet. It's a big, massive medical journal. So, and it's one of like the most quoted, kind of one of those well-respected journals. So It did take 14 years of global effort, and there were more than 22,000 stakeholders, such as like patients, researchers, and professional societies worldwide that went into making this decision. So it's not just like one day some person was like, hey, this is really more than just the ovaries. Let's call it PMOS. I mean, this was like multiple years in the making. And there was over 56 international organizations involved. So I think that is so cool.
It is so cool. And, the whole goal there was to help improve the, getting diagnosed, reduce the stigma around it, and highlight the endocrine and metabolic components that were a lot of times overlooked. I feel like PCOS just was kind of a thing to do with your ovaries, with your periods, with fertility, and there's way more to it. And so that name definitely helps out. And proves that it's like not all about the ovaries.
I know. And then by default, these women landed in the gynecologist's office, and then the gynecologist wasn't really talking to them about their long-term like diabetes risk and their insulin resistance and their bigger cardiovascular risk. And I mean, not necessarily like dogging my gynecologist. I am one, but like they were trying to help regulate their periods, help them get pregnant. I mean, there's a lot of things to do just on the reproductive side of it. And that whole like other endocrine part was getting kind of ignored. So I think this is opening up to like everybody. But it doesn't really change how we diagnose or treat the condition. So they didn't change the diagnostic criteria. They didn't change recommended treatment. But I think what's so interesting about PCOS or PMOS now is that there's not like one hallmark diagnostic thing. We'll talk about this, but there's like multiple ways to get into the diagnosis. And there's not just one treatment regimen. I mean, it's all so individualized. And so that is what makes it more difficult too. But nothing changed about any of that. It's just changing like recognizing the fact that this is not just the ovary or getting pregnant problem.
Yeah. And I think that just helps include all the other healthcare providers taking care of you, whether that's your primary care doctor, family medicine, maybe you need to go to like an endocrinologist, whatever. I think that having that new name makes you realize, it's not just like a gynecologist problem.
Yeah. Yeah. And a little history, I think it's interesting, like, how did we get here? Why do we care? I think it's interesting. But like 1935, we recognized that irregular periods, infertility, and enlarged ovaries were kind of all ran together, and that was a problem for getting pregnant and periods and stuff. And so then in the 90s and the 2000s was really kind of when we realized that insulin resistance was really central to that. And so that's what was really driving all of those problems with insulin resistance, which at face value may seem like it has nothing to do with your ovary. Like insulin comes through pancreas, it controls blood sugar, what does that have to do with the ovary? So making that connection was pretty big. And then in the 2010s, we learned that the condition affects cardiovascular health, diabetes risk, fatty liver, and mental health, and as well as like sleep disorders and things like that. And so we really started to see like, okay, not only is this not an ovary problem and has to do with insulin resistance, but it's branching out into like other medical problems that have nothing to do with an ovary. So, and then here we are, 2026. We have finally found a name that encompasses all of it and really sort of explains it better.
That's right.
Yeah.
Yeah. So let's talk about like what specifically is PCOS or PMOS. It's going to be hard for us not to call it PCOS. I've been doing that for so long. So just they're interchangeable at this point. It all kind of means the same. So,
right.
So PMOS is a complex metabolic and endocrine disorder that really involves a spectrum of issues. So women fit into one of four main categories, and those categories are insulin resistant, hyperandrogenic, meaning like higher or excess testosterone levels, ovulatory dysfunction, and then polycystic ovaries on ultrasound.
Yeah.
Yeah. And then the criteria for diagnosis, it does not include the insulin resistant part.
Yeah, it never has, which is very frustrating.
It is.
So it doesn't mandate because of that. Like, it doesn't mandate like that you ever even have your fasting insulin checked. Like, you may have had PCOS for the past 10 years and no one's ever even looked at that.
Yeah. Yeah.
Which is crazy because we know that that's what's driving a lot of them. And it's not like of those 4 categories, you just are going to be one, like, okay, I'm just an insulin resistant person. I don't just have the high testosterone. I mean, most of the time you're some sort of piece of all of them. But, you know, and you don't even technically have to have an ultrasound either because the diagnostic criteria are called the Rotterdam criteria. And you really just have to have 2 out of the 3 things. And that's irregular periods, high testosterone, like either by outward appearance, like, yes, I am having to shave or pluck my chin hair every day. Well, you have high androgens. Like, we don't need to even draw your lab to tell you that. But so it can be outward or like on lab. And then ultrasound findings. So it would be possible to diagnose somebody with PCOS without ever doing an ultrasound, just by listening to their story, listening to their irregular periods. Maybe they have a period every 3 months and then they have 2 weeks apart, or they're just really irregular, not ordered correctly, and they shave their chin every day. I mean, technically you could diagnose that person with PCOS, but what happens most of the time is that people do that. They say, okay, we think you have PCOS, and here's your birth control pill.
Right.
And nobody ever checks like their insulin or any of these other things that can be going on that really need to be corrected to prevent them long term from having problems.
That's right.
So I feel like, you know, we can get wrapped up in these diagnostic criteria and be like, well, you met the diagnosis, so here you go. But yeah, and you also can see where you might, you know, end up leaving some people out, like thinking that it's like people like me, like, okay, you're not overweight and you're not shaving your chin every day, so you are probably fine. Maybe you're just too stressed out and that's why your periods are irregular. I mean, I've told those kinds of things.
Yeah.
Like, you know, you're in med school, you're in residency, you're just stressed. Like, calm down. You're high strung. Like,
I feel like today, like, you as a provider, you cannot get away with saying that anymore.
you can't.
And there's too much available, like research and all the things out there and social media.
Yeah.
Like, no patient really is going to take that as an answer anymore.
Right.
That will prove it to me. You know, do some labs, do some ultrasound.
Yeah, and I think what's dangerous, I mean, there's a lot of dangerous things about just saying that and not proving it. It's like long-term high testosterone, like maybe I got lucky because somebody slammed me on a birth control pill when I was 15 and downregulated my testosterone in that way. But maybe I got lucky because let's just say I would have had the kind of mom who's like, we're not doing birth control, you know, that kind of thing. And then I could be the person with chin hair today because I wouldn't have had that, or, you know, and then just when we started doing this hormone stuff, I mean, 3 or 4 years ago, my fasting insulin was 40. I mean, nobody's ever looked at that kind of stuff. So would I have been a setup for diabetes later? Or a beard? I mean, we don't know.
Yeah. Well, probably that above, you know?
Yeah, but yeah. I mean, luckily we know more and can do better. But yeah, I do think it is possible to say, yeah, we think you have PCOS based on your irregular periods and your signs of androgen. But I don't think I'm not saying we should do that. I'm saying, you know, we should dig further because it may be okay right now, and they may not have those outward signs, but later on they may get those. So, and PCOS is so common. I almost made the hook, like the thing that makes people want to listen to your podcast at the beginning. I almost said, one of your friends has PCOS, and you don't even know it. Yeah, but I thought, you know, that's coming at people a little too hard on a Monday morning when we're recording that. But it is PCOS is so common. I mean, it's 1 in 10 or up to 1 in 7. So, like, yeah, when you're out with your group of girlfriends, there's like 7 to 10 of you, probably one of you has PCOS.
Yep.
That's right. It's that common. So that's going to be about 8 to 13% of reproductive age women, and it's one of the leading causes of infertility and metabolic.
That's right. Yeah, and up to 70% of women remain undiagnosed. Symptoms can start in adolescence, and it affects your hormones, your metabolism, your reproduction, and your long-term health. So just like kind of we were saying, staying insulin resistant for a really long time have big repercussions on, maybe developing diabetes, cardiovascular disease, long-term stuff like that.
Yeah, and that's what, I think that we are passionate about the 25-year-old with PCOS who, either needs birth control or wants to get pregnant. But to me, that is such a well-established pathway, and most people do know how to treat that. What people don't know what to do with is the 40-year-old who's done having babies and just is this PCOS patient and moving forward, and for long-term health purposes, what do we do with her? And that's what I feel like people don't know. It's well, I don't know. It's not really a problem that you don't have your period, but every 4 months, you probably enjoy that, right? It's fine. And you're not trying to get pregnant anymore, so it's fine. It's no, it's not. So I think that's what's really been the missing piece. Everybody's passionate about birth control and getting babies here, fertility stuff. Everyone's passionate about that. People become less passionate about the 40-plus population.
Yes. And here we are riding in Hump Day hormones. Give me a perimenopausal girl all day. That's my favorite.
I know. And I think that a lot of these, 70% remain undiagnosed. That's huge. And how is that so? And I think that's because they end up, you really end up maybe at the dermatologist for your acne or your abnormal hair growth. And then, at your gynecologist for your irregular periods. And then at your PCP because you've got these little things called acanthosis nigricans that are all of a sudden appearing on your neck because you're so insulin resistant. You end up at a whole bunch of different doctors and nobody ever puts all the pieces together.
Right.
Yeah, that's exactly right. So you just need somebody that can connect the dots. And I think that that's what PMOS is trying to do. It's saying, okay, we're trying to get all specialties involved here and connect the dots. So the current name change, or the current name, PCOS, kind of what it got wrong and why we needed a name change. What was the point? Why can't we just keep calling it PCOS? We've been doing fine. Y'all figured it out and made a podcast about it. Why can't we just keep going? And I think, it's the same thing we've been saying. It's not all about the ovaries. It's not ovarian cysts. And I think that's one, kind of thing that I would love for everyone to know is that when we say polycystic, or the old name, it means a bunch of tiny, tiny, tiny little, they're actually follicles. We're not talking about a cyst you hear people having a big ovarian cyst and having to go have surgery, or a big ovarian cyst that's causing them a bunch of pain, or got so big that it forced their ovary. It's not that. We're talking about tiny, tiny little millimeter-sized follicles, and we are supposed to have follicles, so that's not weird. But polycystic or PMOS girls have way too many of them, so they're just their ovary just is speckled with them, rather than just having a couple here and there. And I think it just depends how deep you want to dig and be scientific and nerdy about it, but y'all know I got to do it. I have to know why. Why is my ovary polka dotted and somebody else just has 7 little normal looking follicles there. And all of those follicles contain your immature egg. And so that's what will ovulate and get you a baby someday. So that's what I love for PCOS girls to know is you're not infertile. You actually have a whole bunch of follicles. But the scientific nerdy explanation is that we have more stimulation to our theca cells. So the theca cells are what makes androgen. And so what you need to be stimulating every month are your granulosa cells. Your granulosa cells make estrogen, and they cause that follicle as well and get pretty big and then pop and ovulate. When you're stimulating theca cells, you're not going to create an ovulation. You're just going to create a whole bunch of testosterone production. And so, and then interestingly enough, insulin can stimulate a theca cell. And so then you become this round and round wheel of like, I'm insulin resistant and my insulin is stimulating my theca cells and my theca cells are stimulating more androgen production. And then just round and round you go. And then there's like this chronic low grade inflammation that we think PCOS, PMOS people have, with whether that's cortisol or C-reactive protein or whatever kind of, name you want to put on that. There is some low grade inflammation, that is continually stimulating theca cells. And then there's scientific evidence that like BPA and phthalates, those are environmental toxins. Those can stimulate theca cells. And then this is real nerdy, but LH, the hormone that's supposed to spike right before we ovulate, it stimulates theca cells too. That's why we have a little testosterone uptick right before ovulation. But LH stimulates theca cells, and they've done this like genetically looked at women who you're supposed to have these like pulses and they're supposed to be released at a certain interval, but genetically PCOS girls have more LH pulses. When they looked at their LH pulses, they happen more frequently over a 24-hour period, and that is going to abnormally stimulate those theca cells. And so there's just like multiple reasons that it's happening. But when we say cyst, we're talking about, now all these little tiny follicles that are your abnormally stimulated theca cells.
Well, and I think that's kind of where the confusing part was with the PCOS name is somebody hears that they have a cyst on their ovaries and they're like, oh, do I have PCOS? I'm like, no, that was like, no, it's just your cyst or something like that.
Yeah, you have an ovulatory cyst. You have an idea of a PCOS girl had. You were trying to ovulate and made a cyst out of it. Yeah.
Yes. Yeah.
So, yeah.
Well, and like, people with PCOS may or may not have cysts. You don't have to have, it's kind of in that diagnostic criteria. You don't have to have cysts.
Yeah.
So I think that's where kind of the name change is helpful because it takes out the word cyst, because there's multiple reasons that you can have a cyst.
Yeah. I think it would be fun to walk through, like 4 kind of like patients that we see, like patients that walk in our door and what are their symptoms. And so 4 types of patients that we see that all have PMOS, but they present so differently. Yeah. So I think that's fun. So patient number 1, she's the infertility patient. So she comes in saying, 27 years old. I got married a couple years ago. I've been trying to have a baby. I can't get pregnant. And then you, of course, start asking all your questions. I have a regular period. So then I may skip a period for 3 months. Then when they do happen, they're kind of heavy, but then maybe 2 months. I just never have a period that is normal, like timeable, like fits in that 21 to 35 day cycle. My cycles are always longer than 35 days. Those people are really not ovulating. So they're obviously going to have a hard time getting pregnant because they're not ovulating. And I think that is classically probably any gynecologist who's done an intern year can figure that out.
Diagnose that.
Yeah. That's easy.
Yeah. Okay. Here's number 2. So this is like the metabolic girl. So she's overweight or has had a significant weight gain. You find that she has an elevated fasting insulin level, an elevated A1C, kind of in that pre-diabetes range or sometimes full-blood diabetic. So, Yeah, that one is probably hard to diagnose, and it's probably misdiagnosed or underdiagnosed because maybe they're just looking at the weight aspect of it, maybe maybe she didn't have irregular periods, maybe she's not trying to get pregnant, maybe that's not one of her deals right now.
I think of this as the 40-year-old who comes in basically for weight loss. They're just like, I cannot lose weight.
Yep.
I am trying to eat the healthiest I can eat. I mean,
nothing's budging. I tried all the things.
I work out. I do all the things. And nothing's budging because this insulin-resistant weight gain or really inability to lose is pretty crazy. So, yeah, that person really presents themselves as a weight loss patient. And then patient number 3, they're the androgen dominant patient. So they a lot of times probably end up in their dermatologist's office, but sometimes they're just here getting their yearly pap, and we'll talk about things too. But they have acne, they have facial hair, and then the hair on their head is thin, so they're losing hair on their head, but getting hair on their chin, sometimes on their chest, and like happy trail area, and then they really struggle with acne, and so. Like I said, most of the time they may end up at a dermatologist's office. They'll usually come in saying that they've been on biotin or whatever kind of hair supplement you can have. They've tried every acne cream available. I mean, but most of the time, they've never had a lab. They don't even know that testosterone could play into that.
They just think it's all kind of a skin and derm issue.
Yeah.
Okay, and then patient number 4 is you.
I'm the problem.
This is the hidden patient. This is the hard patient, right? So she walks in, she's cute and she's little, and has no signs of like excess testosterone, maybe a little bit of acne, but seems to be okay.
Yeah.
But significant insulin resistance.
Yeah.
Nobody would have looked at you and thought you're insulin resistant.
Yeah, and I feel like too, it's like, I took birth control pills from literally when I was like 15 until I wanted to have a baby. And so I don't know what my periods were like. I really don't. They were kind of like non-existent because I was on birth control. And I do remember thinking it was weird that I wouldn't even have periods on birth control, but I just thought, now I would probably say, well, people on long-term birth control pills sometimes get such a thin lining that they just don't have a cycle. So we kind of covered up the cycle part of it. Probably if I hadn't been on birth control, I would have probably had a lot more testosterone effect, and I probably would have had some irregular periods. But, it was just really until I just wanted to know all my labs and figured out how insulin resistant I was. I figured out how PCOS I was when I couldn't get pregnant and had ultrasounds and labs and everything like that. And my LH always, on every lab I ever checked, was crazy high. And like on every single like ovulation predictor stick, those are detecting LH. I could take an ovulation predictor stick probably right now and it'd be positive. They are positive all the time because my LH is just chronically high.
Yeah.
And so I really think that I have some form of like genetic PCOS, inappropriate pulses, and inappropriate LH production.
Which make it really hard to figure out like if you're ovulating, when you can try, how to get pregnant, all the things, if you have a positive LH every day.
Yeah.
Like, well, you're ovulating today, tomorrow, and yesterday, off days.
I know. Before we kind of figured that out, I was like, literally, I'm like on my period, but my ovulation stick is positive.
You're like, wait, that doesn't make sense.
Yeah. So, and then I was like, finally, let's just look with ultrasound. And I started bawling, crying in the middle of my ultrasound because it was like, you could look up from across the room and be like, yeah, that's PCOS ovary.
Yeah.
So anyways, it's all good. Here we are with 2 kids and got that insulin under control. And this is why too I'm such a big fan of GLP-1s, like y'all probably heard last week. I think we didn't really have those back when I was first getting diagnosed and all that kind of stuff. but I needed something like that, not to lose weight, but to get less insulin resistance. So I'm somebody who could probably microdose and get big benefit out of it.
Mm-hmm. Mm-hmm.
Also, this is like has nothing to do with PCOS. I mean, it kind of does because the insulin resistant. Did you see like this weekend?
Mm-hmm.
It came out that there was a study released that GLP-1s may reduce the risk of breast cancer by 30%.
I mean, add it to the list.
I mean,
Sign me up.
I know. So anyway, yeah. And then long-term risk associated. So one of the biggest reasons why this matters so much is because there's all these long-term risks. So obviously insulin resistance, diabetes, fatty liver disease, which we end up seeing quite a bit. You know, sometimes you see it just with like slightly elevated LFTs. I always kind of, you know, want to dig deeper, do an ultrasound, and you see a fatty liver, and like you're like, dude, you've been insulin resistant a long time, but now you have a fatty liver.
Well, I think we've talked about this before. You know, kind of the hallmark classic, like gallbladder disease, you know, is like you're 40, fat, and fertile.
Yes.
I'm like, well, really? You've been insulin resistant the whole time.
Yeah. Or like Rousier, Dr. Rousier that we took those courses from. I mean, he was an ER doctor, like by original training. And he said in the ER when they would be doing, you know, CT or ultrasound for other reasons, and he would see a fatty liver, he would be like, oh gosh, you have PCOS. And they're there for something totally unrelated. But yeah, by the time you can see a fatty liver, you've been at it a little while.
That's right. Yeah. And so some other conditions that this like can lead to is, I mean, infertility, obviously, sleep apnea, cardiovascular disease, anxiety and depression. So that has a lot to do with just your lack of progesterone. You're not ovulating. You're not making your own progesterone. I think you're under where that comes from. Endometrial hyperplasia, so kind of that thickening and overgrowth of the lining of your uterus from not ever ovulating, not ever producing progesterone. You're not ever really shedding that off. So there's potential that can happen. Potential that it could eventually turn into cancer as well. You're just kind of making a whole bunch of estrogen without any progesterone there.
Yeah. And I think too, I mean, I only say that because, again, this was me, but there's also this other subset where, and I see this quite a bit in the fertility world, where, you know, PCOS girls don't, like I said, they're not stimulating those granulosa cells, which are what get your estrogen really, really high. And so they make some estrogen. Obviously, they have appropriate breast development. I mean, you have estrogen, but their level never hits those massive peaks because in order to ovulate, like your little granulosa cell had to get so big and that egg really get mature and ready to ovulate before you're going to get up there to 200, 300 and sustain for a couple days to tip over that ovulation. And so sometimes PCOS girls never do that. They chug along with these little like 50 to 100 estrogen levels, which is enough to get the job done for breast development and things like that, and enough that you don't feel like a menopausal person. You don't have hot flashes or you don't feel like a menopausal person, but it's not enough to stimulate a growth on the lining of the uterus. It might be if you don't have a period for a whole year, then you might get this big old thick lining on your uterus. But month to month, it's not thick enough to have a period with. And it's definitely not thick enough to implant a baby on it. You have to have some thickness to be able to implant a baby there. So sometimes, I mean, I know it's classically in the textbook and on the list that we worry about endometrial hyperplasia, which would be abnormal thickening. But I feel like what we see a lot more is like almost like atrophic endometrium around this kind of dull, low level, not ever hitting peak estrogen exposure. So, you know,
kind of both ends of the spectrum there, especially with fertility that I'm trying to get pregnant.
Yeah.
And periods. I mean, like all the reasons, right? And irregular periods.
And I feel like if you've been listening, then you can answer this question. Do you outgrow PCOS? I mean, like, obviously, no, you don't. You don't outgrow PCOS. I mean, your symptoms evolve and the risks change. And like, yeah, you may not be worried about getting pregnant anymore. You may not be as worried about acne because just as our hormone production dwindles, our estrogen, our testosterone will too. Our skin will become more dry and kind of, all the normal changes that we normally see, which can actually be beneficial for a PCOS person. But you don't outgrow it. It doesn't go away. So yeah, in your 40s, you may start struggling with insulin resistance and weight gain, ability to lose, and then in your 50s, you're struck with cardiovascular disease and diabetes. And so, we have to monitor these people long term.
I have a lot of girls ask, especially those girls in like their 20s and 30s, like, did I do something to contribute to this? Did I make myself have PCOS or whatever, and that answer is also no. Like,
Right.
For whatever reason, you were kind of, predisposed. Get on.
Yeah, I really think, I'm just convinced of it, that it is like a genetic LH pulses. And you're probably like, shut up about the LH pulses, but it's crazy because when you think about it, that's coming from your hypothalamus. That's like,
That's your brain.
that's the most primitive part of your brain. That's like,
like you ain't doing nothing to like mess with that or make it better.
Exactly. You can't fix your hypothalamus.
Yeah. Which, that all makes sense. I think insulin, dysfunction or whatever kind of plays in as well. And I think sometimes, especially whenever you see these little young girls, like little teenage girls that are already PCOS, like you didn't do anything. That was how you were.
I think there's stuff we can do to make it worse, like all the inflammatory environmental things. That's not helping just because insulin's so inflammatory. But and then our diet. And when you get into like treatment, that obviously isn't that the first thing every doctor or anybody always says is the treatment is like diet and exercise. And sleep. Don't forget, don't stress out and sleep a bunch too. Those are like always annoyingly on the list, but yeah, for PCOS, no shocker, that's on the list, but like specifically dietary modifications would be like a low glycemic diet. So like less carbs, less refined sugars, more protein, more muscle resistance training. You'll soak up a lot of that glucose and drive down your insulin. And then, everybody needs to not stress a lot. That's it. Just everybody do that, we'll be good. And then medications we use in this space, like spoiler alert, it's not always just birth control. Sometimes birth control is a good part of the picture, right? It helps regulate cycles, helps you keep from getting pregnant. So like in a 20-year-old, maybe that is appropriate. Also, have you looked at her insulin to know you may need an insulin sensitizer too? And so we have good over-the-counter insulin sensitizers that have been well studied, like berberine, inositol, myo-inositol. All those are good over-the-counter that have good scientific data behind them. And I think it's fine to use those. But I think whatever you're using, we need to know if it's working. And so we usually recommend looking at your insulin again in 6 months or so and making sure that whatever you're using is controlling your insulin, bringing it down into more of that normal range. And so there's also prescriptions. There's metformin it's been around forever. It's so cheap. It's got some GI side effects, make it not super popular, but it works great. And then there's the beloved GLP-1s that we have now that just do it better than everything else. But there's a whole bunch of options, and I'm not saying that there is one exact pathway. Like maybe you do need a birth control pill, and birth control pills do lower your testosterone, like straight out of your ovary, lower your testosterone, and they increase your sex hormone binding globulin, so you don't have as high free testosterone. So like for a 20-year-old who struggles with acne, that's awesome. Yeah. But for a 40-year-old whose testosterone is coming down and who doesn't really have acne anymore and whose husband's had a vasectomy, that's not the treatment for PCOS. Right. I know I'm gonna get mad about it.
Yeah. Well, I also think too, in these younger girls, maybe that are not on birth control because somebody told them that they were infertile because they had PCOS, couldn't get pregnant anyways, but their doctor puts them on metformin or a GLP-1, and then lo and behold, they're pregnant. Like, woo! I mean, I think you have to have, I think in this whole treatment plan, you have to have that conversation. We're going to improve your insulin. If you don't want to get pregnant, let's also do something about that. It's gotta be both kind of thing.
That's right. I think continuous glucose monitoring is great. I think some people maybe that didn't know that they were insulin resistant and just found that out. A continuous glucose monitor can be helpful to let them be able to see like what foods they eat that really shoot up their glucose.
Mm-hmm.
Some people are kind of shocked by some of that stuff. And then, I mean, people like Meg Green, who's a dietitian here in town, who's been on our podcast 3 or 4 times now.
Uh-huh.
I mean, nutritional support is amazing. I mean, you know, there's so much that you have to sometimes relearn how to eat, you know, low glycemic index kind of food.
Mm-hmm.
And if you've not really been taught that or raised that way or not ever had to think through that, people like Meg can be really helpful.
Yeah. So I think kind of the important point is that treatment should target hormones and metabolism. And this is kind of why birth control pills are not the only option and not like a true treatment.
Yeah. I think it's easier. It's easier to say, oh, you have PCOS and here's your birth control. Have a nice day. That's easier than being like, you have PCOS and let me open up this little treasure trove box and tell you all the things that we need to work on.
That's right.
And so I think a lot of times when you're first diagnosing PCOS, it is very overwhelming. And I think that it's good to like have a follow-up. Like, we think you have PCOS. We want this to be our initial plan. And then let's have a follow-up in 3 months and rediscuss. Sometimes it takes people a minute to like soak it all in. And like, we all live in a day where no patients are going to go home and Google or ChatGPT or whatever.
No,
and that's okay. You know,
and back with more questions.
Yeah.
I think it's definitely not a diagnosis that you get, and then it's like, okay, see you next year at your annual. Like, I mean, it's almost like a perimenopause menopause kind of diagnosis.
Yeah.
Like, this is going to be kind of an ongoing, continuous, you know, maybe changing treatment plan as we move forward. And like, what are your goals? Are we trying to get pregnant? Are we trying to just correct periods, or are we past, you know, fertility and just trying to live more optimally and not have heart disease and diabetes and all the things. So
that's what I'm trying to do. Yeah, and the whole like just don't stress and sleep more. That part of it's not really going so well, but we got this insulin resistance under control, and we're on progesterone, so we are making headway.
Right.
But I think in closing, if this name accomplishes one thing, I hope that it helps women understand that it's simply an ovary problem. PMOS is a whole body hormonal and metabolic condition, and recognizing that can lead to earlier diagnosis, better treatment, and better long-term health. So, that's right. With her famous disclaimer.
I know, I feel like I could almost say it without looking.
Yeah.
So look. So, quick reminder, everything we talk about here is for informational and supportive purposes. It's not medical advice. Your body is unique, so be sure and talk to your healthcare provider before making any changes to your health routine.
Yay! If you have a friend with PCOS, share this episode with them. You know you do, because if you've got 7 to 10 friends, one of them's got PCOS. So, yeah, share it with them. And come see us here at the Women's Clinic. Follow us on social media. Email us your questions or suggestions for the show, humpdayhormones@gmail.com. And y'all have a great week.
Bye.
Bye.